Good morning from Ranger Camp, where all the written board Rangers are working hard and preparing for a decisive victory. Today I'd like to cover some important topics, namely 5 of the lock and load topics. The American Board of Anesthesiology and the American Society of Anesthesiologists meet periodically to provide feedback to training programs so that didactic efforts for residents within these programs improves. Most residents are still waiting for this improvement, with many feeling more like slaves than students, but the committee has now released over 40 topics, or what they call misconceptions in specific areas of the knowledge domain of anesthesiology, namely what I call our lock and load targets. I'll read the topic area, or quote-unquote misconception, and will then proceed to address it in the detail required for the July examination. Our first lock and load issue is somewhat surprising, but according to the board, 2/3 of CA3 residents failed to acknowledge that nitrous oxide has myocardial depressant properties. Barish states, when given alone in a 40% concentration, nitrous oxide can decrease cardiac output. When nitrous oxide is given to patients with heart disease, particularly in combination with opioids, it causes hypotension and a decrease in cardiac output. 2/3 of CA3 residents failed to acknowledge that nitrous oxide has myocardial depressant properties. Clearly, it does. Turning now to lock and load number 2, according to the board, 1/2 of CA3 residents did not recognize that nitrous oxide has a depressant effect on somatosensory evoked potentials. Barish states, anesthetics produce significant changes in somatosensory evoked responses. Cortical responses are more affected than subcortical responses, he states. Volatile anesthetics produce a dose-dependent decrease in amplitude and increase in latency in cortical components of SSEPs. Nitrous oxide decreases somatosensory responses and may produce greater attenuation of these responses than low concentrations of volatile anesthetics, close quote. 1/2 of CA3 residents did not recognize that nitrous oxide has a depressant effect on somatosensory evoked potentials. It does. Again, nitrous oxide decreases somatosensory responses and may produce greater attenuation of these responses than low concentrations of volatile anesthetics. With respect now to lock and load number 3, according to the board, only 1 in 4 CA3 residents identified that one of epinephrine's roles in the therapy for anaphylaxis is to stop the release of vasomotor mediators during the reaction. The beta effects of epinephrine inhibit the release of histamine from mast cells. Barish states, quote, epinephrine is the drug of choice during anaphylactic shock. Alpha adrenergic effects vasoconstrict to reverse hypotension. Beta-2 receptor stimulation bronchodilates and inhibits mediator release by increasing cyclic adenosine monophosphate, CAMP, in mast cells and basophils. Only 1 in 4 CA3 residents identified that one of epinephrine's roles in the therapy for anaphylaxis is to stop the release of vasomotor mediators during the reaction. Again, epinephrine does inhibit mediator release from mast cells and basophils. With respect now to lock and load number 4, according to the board, 1/2 of CA3 residents thought that 2+ mitral regurgitation is a reason for high pulmonary artery pressure and an underfilled left ventricle on echocardiography. I wasn't sure myself until I did further research whether 2+ mitral regurgitation causes high pulmonary artery pressure and an underfilled LV or not. Typical of the board, the statement can be interpreted either way, and the textbooks aren't much help. A recent review article clarifies this issue and leads me to conclude that 2+ mitral regurgitation is not severe enough to result in high pulmonary artery pressures and an underfilled left ventricle. The article describes a semi-quantifiable grading system of mitral regurgitation based upon color flow echo mapping and from 0 to 4+, according to the maximum systolic length of the regurgitant jet in relation to the atrium. 0 is assigned for no mitral regurgitation, 1+ if the jet extends immediately behind the valve, 2+ if it extends up to 1/3 of the length of the atrium, 3+ if it extends up to 2/3 of the length of the atrium, and 4+ if it extends more than 2/3 into the atrium. After an analysis from the literature of pulmonary venous flow patterns and pulmonary congestion caused by high pulmonary venous pressure, 1 to 2+ mitral regurgitation is not apparently associated with a higher morbidity and mortality compared to 0+ mitral regurgitation. 1/2 of CA3 residents thought that 2+ mitral regurgitation is a reason for high pulmonary artery pressure and an underfilled left ventricle on echocardiography. In fact, 2+ mitral regurgitation would not seem to result in significantly elevated pulmonary artery pressure. Lock and load number 5 is interesting. According to the board, over 1/2 of CA3 residents would use atropine as an initial resuscitative maneuver in a newborn with bradycardia at 1 minute. Keenan and Boyan found that 13 of 14 adult cardiac arrests were preceded by progressive bradycardia. They found that atropine was administered, wasting time. Atropine is often a temporizing measure, but is undesirable if it delays complete differential diagnosis and treatment of the underlying problem. The initial resuscitative measures in a newborn bradycardic at 1 minute must center upon oxygenation and ventilation of the child. Barish states, if initial resuscitative methods, including rubbing the back or slapping the feet once or twice, are not successful, and the patient is apneic with a heart rate below 100 beats per minute, positive pressure ventilation by bag and mask should be instituted at a rate of 40 breaths per minute. Over 1/2 of CA3 residents would use atropine as an initial resuscitative maneuver in a newborn with bradycardia at 1 minute. This is simply incorrect. Having completed 5 lock and load topics now, let's boil some water and make coffee with a favorite Ranger report from one of my favorite warriors, Ranger Jim. Dear Coach, after 16 tries, thousands of dollars spent on courses all over the country, years of shame for not having passed the boards, I received notice 2 days ago that I finally passed the written exam this year. I know that I was able to pass because of Big Blue and the course in Chicago. I was sick of all the study materials I had before, but I was immediately motivated by Big Blue. I couldn't believe how focused I was and would sometimes study for 3 hours straight without a break. I was still able to concentrate. I went through Big Blue 5 times. The course was also extremely helpful. It focused me on weak areas and was a very efficient way to review. I cannot tell you what it means to finally pass this darn test. Just consider it. My daughter was 10 when I started. She's now 26. I will never again have months of every year ruined by constant and ineffectual study. Quote-unquote vacations to useless courses when I should have been with my family, listening to the elite of anesthesia giving the same canned, useless speeches. Board certification is finally within my grasp. Ranger Jim, by the way, passed the written, and then went on to pass the oral the following April. It was wonderful to work with him in both settings. In my mind, the acid test of a program is whether it can make a decisive difference when all other approaches have failed. And this is precisely why I'm so proud of this particular letter. My daughter was 10, now she's 26. John Lennon was right. Life is what happens to us while we're making other plans. Prepare hard and prepare effectively with relentless focus upon exam requirements and content, and get this test behind you as soon as possible. I hope this preview of the lock and load topics has been informative and helpful for you. I'd certainly welcome the chance to work with you through either Big Blue or Audio Blue or one of the other products, or at the course itself. I hope to see you there. Farewell now from Ranger Camp, where all the written board rangers are working hard and preparing for a decisive victory. As Sun Tzu said, victorious warriors win first and then go to war, and defeated warriors go to war first and then seek to win. Onward now to victory.